Hello, everybody. It is great to be here one more time today. My name is Gary Fowler. I'm the CEO, president, and founder of GSD Get Shit Done Venture Studios, a premier AI and quantum venture studio located in the heart of Silicon Valley. I'm a 17-time serial entrepreneur with several unicorns under the belt. I was on the original management team at Click Software, which was sold to Salesforce for $1.35 billion, and also Eva.ai. We believe at GSD that intellectual capacity is evenly spread around the world, but opportunities are not. And this is our edition of Top Global Startups, the best, most exciting startups in the world. And today we have Robert Lauritzen from Cerebriu, one of the cohort companies at GSD. And we're going to talk about his company and also Apollo and how he's changing the health tech world. Hi, Robert.
Hey, Gary. Good to see you.
So can you just introduce yourself and share a brief overview of the journey with Cerebriu and specifically about Apollo?
Would love to. So I'm Robert Lauritzen. I'm the CEO and a co-founder of Cerebriu. I've spent my life in medical imaging and medical device and in pharma. And I started Cerebriu 6 years back with my co-founders to make a difference in clinical practice. And really what we started on was to look at the workflow. So healthcare is a production and the workflow seemed to be getting out of sync. And we looked at the opportunity through automation, through AI, to dramatically improve workflow efficiency in the operation by supporting the people with sort of companion technology that could make things simpler, easier in a stressful environment, so they could focus more on patient care, on patient pathways, than to operate the knobs of a very complicated machine. So we started the technology in the brain MRI space, so advanced diagnostic imaging, 3D imaging, and our on-device find critical findings after a couple of minutes on the table in the scanner, and enable through a single click the adaption to ensure the first-time right imaging, and that the patient can be managed going from maybe a headache to an identified potential tumor or whatever it might be that would warrant a change in the management of the patient, and certainly a much better management of the patient, improved patient care and outcome.
So, as we're talking about that, what are some of the biggest challenges that those radiology departments face today, specifically regarding the MRI workflow? Because, there's this, we talk about medical infobesity, the problem with a lot of the hospitals, with the challenges in the medical. It's not that we don't have answers, but we can't find where the problem is. So how do you solve that? And let's talk about the MRI workflow.
Yeah. Well, I think generally in radiology, like in all clinical domains, there is a lack of staff. There's a staff shortage, and you see the basic trajectory of the growth of staff to the growth of population and the growth of demand. That just the gap grows every year, and year compounds to a point where now you see, especially with the neuroimaging, with the dramatic aging population, because we're getting better at detecting disease, the growth is actually exceeding the capacity growth by more than 10 up to 20%. So you imagine you working 20% faster next year, 20% faster the following year, eventually things will start collapsing. So we see the symptoms of that through increased burnout rate, through increased partial time employments, because people can't stand the pressure of this work. So when we look at workflow, we look at what can we do to make it simpler, to have less data, to have more attention to where you need to spend your expertise, and to provide throughout the workflow, starting from the imaging equipment on the scanner while the patient's on the table, already then starting to change what is going on today, and to affect the downstream to the radiologist, et cetera. So when we're looking at the workflow, we're looking at it specifically within MRI. We're looking at it from planning through acquisition to interpretation and reporting. How can we affect it with upstream AI injected into the scanner so that we can start doing the better imaging, the more appropriate imaging, using the least possible resources, capacity, et cetera, and generating only the necessary imaging for the physicist to be able to provide a diagnosis. And this is just not really possible without technology, because the technologists there take good pictures, but they're not clinicians. And there's so much that's going so fast that nobody has the time to look at the data while the patient's on the table. So introducing, advanced clinical AI into the modality itself, which is what we do, is actually the pivotal change that's transformational to the point of disruption.
So let's talk about it. We talk about the hospital operations side of it, but how do these workflow inefficiency impact the patient outcomes?
So you're looking at if you have a severe headache and you're concerned, you go to your physician, you get a referral, you go to a scanner as fast as possible. Now, as fast as possible in Europe, in many countries now, is more than 6 months. In the UK, it's 2.5 years. And what you're really concerned about is you obviously you hope you're not having a stroke or something, but it could be a tumor or something else that you want to have treated.
No, Robert, how can it be? I mean, what's wrong? The system, we have inefficiencies here in the US, and we have concierge doctors, and it should be for everybody. But it's crazy. You could die, but my wife has stage 2A breast cancer. And in the beginning of this process, if it wouldn't have been for concierge doctors that we know, I mean, seriously, that was like, I've never seen it. They don't care. It's not they don't care. Maybe it's because they intellectualize, right? But you could die before you get to the hospital to get treated. It's insane.
Yeah, it is insane. And really, I think, obviously in the US, it's more costly, right? The US spends 4 times more per GDP per capita than in Denmark, for instance, on healthcare. So it's a big fat juicy machine.
Yeah, but we don't live as long. Here's the thing: we spend more money, but that's kind of crazy.
We've got a shorter lifespan. Yeah,
we're eating too many Twinkies or something. I don't know.
Yeah, I think there's a checks and balances of what's going on there that might be sort of not only about healthcare, but even expenditure aside, we're also seeing healthcare systems in the US clogging up. So it's not unusual to have a 3 to 6 month waiting list to get to an MRI. At least if you want to have an affordable, you can always go to premium services and whatnot, but most people can't. And the challenge is then, so if you imagine you're going there, you finally get to the scanner, you do a routine brain scan. It's not really an indication that warrants a full sort of tumor protocol or something else. So you get a routine brain scan, preferably without contrast, and then up to a month later, a doctor looks at the scan. Now, this is also the reality.
I mean, my wife had to say, I got to tell you, when she went through the breast cancer stuff in the beginning, we had to go down through and get an MRI done. We had the same deal. It took a month for the doctor to come back and look at the MRI and to give her an indication on this thing. So, I mean, all the tests that she did, it was crazy.
Yeah.
We were sitting there and, I got it. I talked to some doctor friends of mine and I started pushing, but in reality, it was a center where we did it. They would contract out the radiology, right, to doctors, and the doctors were too busy for 2 or 3 weeks, and they wouldn't get to it. It's nuts.
It's nuts, and it's I think most of us has tried to be scanned and diagnosed and whatever at some point or screened. And it's anxiety builds up and you're sort of worrying about it. Your family and friends are worrying, your wife or your husband, whatever it is, everyone's worried. And it clogs up the system. And believe it or not, actually, many medical doctors are actually quite worried as well because they're frustrated. They don't know what ticking bomb is lying in the pile. So if you imagine some systems in the US we've actually seen have thousands of brain MRI waiting in their backlog. Literally thousands, to the extent that you can have more than 30 days until a medical doctor actually looks at it. Imagine the scanner immediately detects a suspected critical finding.
I love it.
You're at the point of care and the scanner says, whoops, you got to look at this. This patient looks like having a mass that could be a tumor. It needs to be examined further. And even if you don't have the time the same day because their slotting efficiency is so extreme, at least they can schedule an immediate follow-up and they can prioritize that patient on the top of the list because there is a clear, low prevalence, critical finding. you'd want to make sure that you have that sort of turnaround time reduced from 30 days to 30 hours or 30 minutes, whatever is possible. And what we do with our technology is we make that possible. Right? We are building an automation layer, kind of like self-driving cars. We're just doing it in a field where we incidentally save lives instead of just transport them. And I think it's a fantastic opportunity because this equipment is incredibly advanced. There's a severe scarcity, MR techs. So now the healthcare providers are looking for tech assistants or sort of low qualified staff that can just operate the machines, but they have no clue what's going on. They're just taking pictures. So what if the healthcare system at the point of care can immediately see this is a critical find, you need to change pathway for this patient now, not in a month or a week.
I agree. And the system has to evolve to this. There's no question about it. And we talked about the stem cell treatment that I went through. Why aren't these things available for everybody? Why don't we reduce our healthcare costs by getting the problem detected early so it can be solved? Because every one of the cancer specialists that I've met with my wife, it's, get detected early. But how can you detect it early if you can't even get your MRI? You know what I mean? What's wrong with this picture? Okay, I'm in. Let's do it. You know what I mean?
Yeah, exactly.
Insane. So no, I mean, where you're going with this is right. And these, I call them frontier sciences, right? These things that are going to happen. It's like you and I have talked about, it's like having a Ferrari out of the garage. Part of it is people just don't know. And once you start to show, talk about the value proposition and how it's going to help the insurance companies reduce their costs because detection's earlier, it's going to change things. But until they get it, and people are talking about, I was with some of the family offices out in San Francisco recently. We had a direct discussion about this because we talked about things like stem cells and early detection and anti-cancer vaccines, those kind of things. And it's there, right? A lot of this stuff is there, just like Cerebriu today, but they just don't know about it. Okay, let's go down through. I just want to talk about, so let's how does Apollo's approach, how is it unique compared to other AI-driven imaging solutions currently in the market today? What's a differentiation between them?
Yeah.
How much better are you? Let's just say, how much better are you?
There's a substantial differentiation. So the field of radiology AI has been around for more than a decade, like one and a half decades. It's been taking off, really since compute got to a stage where suddenly, wait a minute, this can actually happen. And the technologies, and of course with foundation models, all that stuff is even transitioning faster. But the whole field, the entire field has been focusing on how do we provide the reading radiologist with biomarkers or with quantification, with data that they can accelerate their reporting on, which is great because there's a huge lack of very advanced. It takes 15 years to become subspecialized radiologists, like neuroradiologists, whatever. It's really, really complicated stuff. So that's great, but none of it is focused on the workflow upstream. So what we're doing with Apollo is saying, okay, but what if the scanner can do some of this stuff at a level on par, at least with the subspecialized neuroradiologists? What if we just said within a few seconds or minute or whatever, the scanner is able to provide sort of reliable detection capability, triaging capability, so you could actually manage the change of the patient at the point of care. And this is completely different to what the rest are doing. So we've focused a lot on optimizing and making it super fast, reliable, getting all the clinical validation from Japan through the US and a lot of hospitals in Europe and Middle East and Asia, just to make sure that it's robust, generalizable technology, but also so that it's so fast and so light in a footprint that it can respond real time for the operator. And it has to be real time. Many of the current technologies are, they spend 2, 3 or 4 or 5 minutes, but you can't lie 5 minutes in the scanner and not do anything, because it's just about patient shift and production. So this real time, the combination of clinical intelligence on the device, after 5 minutes in the scanner, we have enough data to find suspected critical findings that can change your life. And then really our approach is also partnering with the manufacturers of the scanner and fully seamlessly integrating on it. Suddenly we're changing the distribution game, because this is not about running in some cloud thing where you're sending data around with all the privacy thing. That's one thing, but just the latency of sending data to the cloud and waiting for it to process through some advanced orchestrators, all very nice, but you just don't have 5 or 10 minutes to send these gigabytes worth of data. So doing it on the device suddenly becomes, it becomes your companion tool, not just for imaging, but actually for clinical pathways. And this is, I think, where we've, designed something that can seamlessly integrate with the equipment. It can seamlessly integrate on the existing user interface. It's easy, simple, and really to the point. It becomes a single-click instruction. It's fully compatible with remote operation or more specialized MR tech, and it just changes the pathway for the patient immediately at the point of care. There's no wait. There's no days or weeks or months later. It's just happening immediately. Everything is enabled at the point of care, and I think that is where we're at this point substantially differentiated and unique compared to the field of technologies that are available today.
So let's talk about, so in terms of roles, what role, if you break down the roles of smart priority, smart protocol, and smart reading, how do they work together? How are they interrelated?
Yeah. So we actually, it's about medical image understanding and the clinical insights, but there are different workflow use cases, and so we have a clinical dimension. We're starting with neuroindications, and then we have whatever's going on at the point of care is immediate during acquisition. And there are two use cases there. One is just triaging the patient, which is just headache in the middle of the night. You go to the ED, you get scanned, CT doesn't show anything. You go to the MR, you're having a hyperacute stroke, which does not go up on a non-contrast CT. You're not having a bleed, and they can certainly change your life. That's smart priority. That's about alerting, because to be honest, the residents are great, but they're quite often not skilled enough to find subtle change that can be significant at the middle of the night. And MR techs in the middle of the night are typically not the senior ones that have a lot of experience, would potentially pick up on it. So this is smart priority. It's just about notifying and changing the pathway for the patient. Smart protocol is saying, but if we know that you're on the table, you're in the scanner, you're in an outpatient center, you've had a headache for a week, we detect a small, maybe benign, maybe not benign, mass effect that could be a tumor. You'd be able to, without a recall, without sort of that whole overlay, just immediately say, it looks like there's something we need to examine further. We can do an extended examination. We can push around our schedule and make sure that you go home with sort of a first conference with your doctor, but also with an immediate sort of read. So you can accelerate the read, but with the right data necessary. So if you go in for a normal non-contrast headache examination, you would not have enough data for the radiologist to complete a diagnostic report, and you would eventually be called back. We want to remove that sort of overhead. We want to create value now that you've taken the time to go to an imaging center, so that you get the information you need, your physician gets the information they need, so you can immediately have a conversation about if there is a serious effect, what's going to happen now, and not go around in uncertainty for days, weeks, or months. So this is the smart protocol and the smart priorities. So those use cases are very much focused around automating what's going on at the point of care. However, not all scanners can do this, right? And not all healthcare providers are ready to, and not all the OEMs are there. We'll get there. We're partnering with everyone. This is going to be the future, but it's going to take a few years to get there. So in the meanwhile, what we want to do is to make sure if you're a healthcare system, you have a 10,000 brain backlog. If there are 500 critical findings in there that we can prioritize and get to the top of that list, we want to do that. We want to help bring that value to the table. This is smart reading. This is prioritizing, not sort of the patient at the point of care, because it could be minutes later, but at least we can accelerate the read so that you within whatever 12 hours, 5 hours, whatever it takes, can get sort of a call from the healthcare provider and say you have something that we need to take care of. And it could be a callback or whatever it might be at that point of time. So this is smart reading. And the good part about that is it doesn't have to run on the machine. It can go into the infrastructure of most hospitals through some of our other partners, where we basically connect their imaging flow with this kind of analysis. It's as fast as it would be on the scanner. It just doesn't have to be on the scanner. So if you have a large system, like some of the large radiology groups, you might have 400 MRI across the country, we could pinpoint at any point in time, where do we see patients, maybe even before they left the center, that has a critical finding, and you could still do good, right? So it's sort of the bridging technology until it's all available on the scanner.
So can you give me, so what are some specific scenarios or examples where Apollo significantly improved the patient outcomes or maybe the clinical efficiency and changed it? Do you have any specific examples?
Yeah, so I mean, the classic example in either in the emergency, but sort of the ED example, where you go there, you have an unspecific headache, neurological symptoms, whatever, where there's not a clear ischemic stroke. You don't really know what's going on, but you definitely want to scan. You would end up in an MRI with the capabilities at the facility. And we have had instances where we've been running in parallel and where we've detected like what is called subacute infarct. So this is sort of later stage infarction, which potentially could turn into a full-blown ischemic stroke again, or just at all. So a condition that is preventable if you do something about it, but where the experienced neuroradiologist at night, 3 o'clock, had missed it. And it might not make a difference, but it could also do a significant difference because it is clinically significant and it can change dramatically in time. So if you're not aware, if the patient's not aware, suddenly something can happen and then you might lose out on an opportunity to save life.
Got it. How do you see, Robert, how do you see AI-driven technologies like Apollo evolving in radiology over the next 5 years? What do you, in your view, what's going to happen in the next 5 years?
So in the next 5 years, I believe that our platform and the approach that we have, hopefully there will be others that will want to contribute in this direction, would be transforming the entire global fleet of MRI equipment towards autonomous MRI. And really what we're doing is we're enabling health equity. We're enabling treatment in populations that today can't get them, or in parts of the country in the US and Europe that just can't afford private care or whatever it might be, and at the best possible level of care. So this, I think, and not just for brain imaging, we're going to be doing other body parts as well. So eventually the scanners will have transitioned from half a century of really good quality imaging equipment to really clinically intelligent autonomous equipment that can be operated maybe even by the patients themselves. So the citizens, you could go to your local mall, you could go to Walmart, you could get a brain scan because you're concerned, and then you can get directions to call your physician. Obviously, you won't say you have a this, that, and the other sort of immediately because it can be, you might not be in a context where that's a good piece of information, but at least, you should contact your physician with this information as fast as possible. That kind of thing, that we could actually be there in 5 years.
Are there any new features or advancements in Apollo's pipeline that you can share with us? What's the future look like?
Well, within this, so there are several dimensions, but within neuroimaging, the next technology that's now in clinical trials and commercial pilots is more advanced treatment decision support for stroke. So the norm is, the gold standard is CT for stroke, which is ruling out bleed and then thrombolize to reperfuse the brain so they get the blood flow going again. To some extent, if it's not a large vessel occlusion, you have to extract that with mechanical thrombectomy. But what we're doing is looking at the people that wake up with a stroke, or that where they're not really sure how long they've had the stroke, because that has implications on whether you can treat or not. And there, the gold standard is actually quite often to move to the MR. And what we're doing then in the MR is actually helping the medical doctors with the very complex biomarkers that the clinical trial says that you can actually thrombolize this patient. That means that you can get the blood flow circulating again with chemical treatment or medical therapy, and providing a more reliable, high performance AI that can provide these very complicated biomarkers where people are dying. So it's an incredibly stressful situation. As a medical doctor, you have to sit and draw today to figure out whether or not they can you can actually treat these patients. That's not a good, it's a good stress test, but it's a 24/7 problem. So what we want to do is provide that metric so they can reliably trust to say that this patient can or cannot be treated, and we can save lives within minutes instead of spending 10 or 20 minutes, which is neurons and disability and all the other downstream crap that goes on. So I think this is a really exciting real-time use, potentially also directly on the scanner, which is it's all about getting the time to treatment down to the absolute shortest possible, because it's all about saving lives and reducing disability.
Yeah, no, you're right. It's about saving lives. It's to be there. Do you want to do it or do you want to die? I mean, the situation, it's pretty simple. And, we've been through those kind of situations. I did with my father when he had a stroke. He went through it. And, there's a lot of advancements out there we just don't know about. And like I said, it's like taking a Ferrari out of the garage. You got to get it out. People have to know about it. I mean, it's like stem cells. I mean, lots of things. But you've done an incredible job, and I know you've raised around you've raised what, over $20 million.
Yeah.
And, you've done an incredible job. So what kind of thoughts, in closing thoughts, what would you like to share to the with the audience, and in particular with startups that are in the health tech field? Any words of wisdom for them?
Yeah, I think it's a hugely complicated enterprise world, healthcare systems and payers and all that. So I think my first advice would be look at a way to partner with organizations that are large, big enough to provide access, and that can, through that partnership, can scale a technology that quite often is great. I've seen a lot of stuff out there that's great, but quite often there's a commercial struggle around, we want to sell directly and we want to do this and that and the other. That's great, but that's just not going to happen. It's a really, really long haul, and it's incredibly expensive, and the sales force is insanely scarce as well, and the access to the people that decide is scarce. So I think that's my sort of number one. I mean, there's so many things we can talk about, raising money, of course, but making a case where you're trying to do something on yourself in a world this complicated is just not going to happen. So look at how you can change, and maybe just think of it with the new technologies that are there. Think of it in the other way around and say, what if, it'd be a little science fiction. What if this was a Star Trek tricorder or whatever, this super cool technology somebody thought about 50 years ago, but it's actually, this is what's happening now. Like, it's possible because of artificial intelligence.
Yeah, I had somebody come up to me actually with something like that. That was a look at a harmonic resonance of a cell, and there were some Stanford and RIT trained doctors. I got them from a ultra high net worth family. Literally developed something like that. It was interesting, but they could actually diagnose diseases using harmonic resonance of a cell. But the thing that was really interesting is not only would it receive, it could transmit harmonic resonance back to the cell and alter it. And they were telling me this is one of the wealthiest guys in the world funded this for his one of his relatives. But it was quite interesting when you start to hear about those kind of things. And 30 years ago you heard about it in Star Trek, and there's and the field today. And the same thing with Cerebriu. The things that, I remember Bones, when he would take people and put them on the lay them on the table and basically do what Cerebriu's doing now. I mean, you're just making it real. So, hats off to you. You've done a great job raising funding, having you in GSD, and to all of you out there. They're great opportunities. You've got to get the Ferrari out of the garage for people to be able to see it. And storytelling is 90% of building a unicorn, and we forget about it sometimes. It's critically important. You can have the best project in the world, the best product, but if nobody knows about it, it doesn't work. Get out there. Don't just spend money on R&D. Get it out to the market and test the market. Do your customer development. Look at partnerships with Siemens and GE and all kinds of different folks that can help your company grow. You're right. Sales and marketing costs are really expensive, right? But if you have a team that's working with you, you can partner. By the way, those also could be potential acquirers, because they know you, they can acquire your company. So it's great having you here. Appreciate you taking time out of your busy schedule. If you want to stay on for a couple of minutes, we can talk. It would be great. My name is Gary Fowler, and I'm the host of Top Global Startups. Robert, thanks for coming today, and thanks to all of you. Stay happy, stay safe, and stay healthy. And I will be back again soon with another exciting edition. We're at 1,150,000 views, and thanks to all of you for making it happen. And always go down through and like and subscribe. Thank you very much.